So welcome everyone. My name's Tracy Comans and I'm the Director of the National Ageing Research Institute. And I'd like to warmly welcome you today to our Seminars in Ageing program. I'm going to begin by acknowledging the traditional owners on the land on which we are meeting today. For me, that is the Wurundjeri Wurrung people. And I would pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander peoples. Firstly, a little housekeeping regarding our teams. The chat function has been turned off. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions during the talk, you're very welcome to submit them using the Q&A function. Or at the end, please feel free to put up your hand and turn on your mic and video to ask a question. But just keep in mind that you will be included in the recording that we're doing today. Today, I'm really pleased to be introducing Dr. Danelle Kenny. And I think the topic of her talk is very serendipitous given the Four Corners report last night. So Danelle is a Research and Policy Officer with the Aged Care Quality and Safety Commission, where she works on regulatory strategy for the Support at Home program. She completed her PhD in 2025. I'd like to say I had a small part in that as her supervisor, but very much driven by Danelle. And it focused on behavioural economics and resource allocation in Australian home care. Danelle has extensive experience in health services and systems, including economic evaluation, quality improvement and dementia care. She also project managed a large MRFF-funded project which developed Australia's first core outcome set for dementia care. Today's Danelle's presentation is titled Home Care Packages and Decision Making. This presentation explores how home-based care can support older people to age in place while making efficient use of limited healthcare resources. This project used Canadian home care data and examined how different levels and types of services influence the duration of home care and the transition to residential aged care, with the idea of identifying service approaches that can help older people remain healthy and independent in the community for longer. So welcome, and over to you, Danelle.
Thanks so much, Tracy. I too would like to begin by acknowledging the First Nations people who maintain connections to the country on which we are collectively meeting today. I'm streaming from Meanjin, a part of the lands and waterways that are taken care of by the Yagara and Turrbal people. I pay my respects to their ancestors, elders, and their enduring cultural connections with the place that I call home. Please do feel free to share the place that you're connecting from today, although if the chat's disabled, you may not be able to do that. Hello and thank you for the opportunity to speak about a topic that has more or less taken over my life since COVID. I am Dr. Danelle Kenny, and today I'm talking to you about a chapter of my PhD research, which the entire PhD is called Heuristics and Biases in Budgeting Decisions for Home Care Packages under a Consumer-Directed Care Funding Model. Well, that's a mouthful. There is a link to the full thesis for anyone who'd like to drill a little deeper into some of the topics, because I only have time to skim over them today. So my deep dive into home care began naively as a simple application of behavioural economic theory to aged care. I genuinely believed that it was only going to take about 3 months that we had funding for to prove my point. After all, how complicated could it really be to provide care to older people where they are when they need it? 5 years later and several hundred grey hairs, I can confirm it is almost impossibly complex. You could write multiple theses and still only scratch the surface. So for the next hour or so, I invite you to come with me on a powerboat ride over the intersection of health, economics, psychology, policy, and people. So we are meeting at a time when every health and aged care system in the world is being reshaped by population aging, and Australia is no exception. Here we have 1 in 6 people who are currently over 65 years and old, and within a generation it will be 1 in 4. The fastest growing group are people over 85, who are those most likely to need care and support and to make the most complex healthcare decisions. Populations getting older isn't the crux of the issue. The challenge is that people are living longer with complex health needs, including combinations of multimorbidity, frailty, cognitive impairment, and functional decline. At the same time, the care economy is shifting. Hospital and residential aged care are costly and not getting any cheaper, often destabilizing. Home care is a comparatively inexpensive and flexible program that aligns with what people want, to remain at home and in their communities for as long as possible. It really is so obvious that governments, clinicians, researchers, supporters, and older people would all then be deeply invested in aging at home. But we've built policy and funding models on the assumption that home care simply works, without fully understanding which services help people stay at home longer, which don't, and how real-world decisions shape those trajectories, which is what we're going to take a peek at today. While we're getting some sea spray here, I want to get you thinking about real-life decision-making. And see, our lives are made up of choices. Some are easy and automatic, and some less so. It's estimated that we make an average of 35,000 conscious decisions every day, roughly translating to 1 every 2 seconds of waking time. But despite all that practice, the evidence indicates we're still not very good at it when it matters. Now, I'm a big fan of interactions in my presentations and have no intention of mass homicide by PowerPoint. So I've built in some interactive touch points. So the green square has a QR code that you can scan with your phone, and to answer the questions, there's a few of them. So this first story goes a little something like this. You are 67 years old and heading home after a fall in the shower sent you to the emergency department. Nothing's broken, but you're bruised and a little bit shaken. Your neighbour gently suggests that a cleaner or personal shopper might help, and your neighbour mentions Bill in number 4 has someone who comes in every week, and it's like his wife lives there again. In this perfect world, there aren't any waiting periods, so you organise a home care assessment, and the nurse visits and explains that your approved package funding can cover one of these 2 options. The first option is physiotherapy and a therapy assistant to help you clean your house safely. Or the second option, a house cleaner once a fortnight who makes you a cup of tea while they scrub the bathrooms. Which one are you going to choose? So I'll give everybody a few seconds to draft a response. Which may not work. It did work yesterday. There we go. So I'll share very quickly. We've had nearly 60 responses. So we can see there that over 65% of people are going to choose the house cleaner, which is sorry, the physiotherapy, which is what we would expect. You can be brutally honest here. I've been researching this for, as I say, the better part of 5 years, and I still would pick the house cleaner any day of the week. And now a slightly different question, the same scenario though. This time it's your GP asking what services you think are going to keep you living independently at home. There's a second QR code. There are not quite as many people playing ball here, but we can see a slight shift away from the house cleaning. And this reversal of preferences, even in a population of people who deal with this all of the time, showcases the perfect imperfection of human decision making with all of the biases in there. So this simple illustration is enough to almost believe that an amateur researcher can answer a question in 3 months. So these responses are a perfect example of how real decisions are made. So when people choose services in home care, they're not sitting down with a spreadsheet or a cost utility analysis. They rely on heuristics or mental shortcuts that simplify the 35,000 decisions that we make every day. Now, these shortcuts are remarkably consistent across global populations and subgroups. An example is the selection of domestic assistance or house cleaning, because this service is familiar, visible, solves an immediate problem, and avoids anything uncomfortable, so it often feels to people like it's the right choice. In home care decision making, I observe many heuristics, but the big players relevant to the discussion today are the availability heuristic, the affect heuristic, status quo bias, and loss aversion. But keep in mind that people often choose what is familiar, they are influenced by how they feel, they like to avoid change, and they dislike giving things up. Heuristics don't make us irrational, they make us human, but they also mean that the choices we make might not really align with the services that keep us at home over the longer term. Heuristics drive the choices made today, while the outcomes of those choices emerge months or even years down the track. So by the time we start to see hospital admissions or a decline in function or premature move to residential aged care, the original decision point is long gone. So understanding heuristics gives us an opportunity to design systems that support better decision making without sacrificing choice or autonomy. One of the clearest findings in my thesis is that decision quality changes over the life course, often declining in older age. This degradation is sometimes due to functional decline, but more often because the environment becomes progressively harsher. Harsh decision-making environments amplify heuristics, the shortcuts become more appealing, and comfort becomes more valuable, and the longer-term thinking becomes much harder. So by the time someone is making these home care decisions, they're doing so in a demanding environment. Everyday tasks take more effort, which means that there's less energy left for decision-making. Processing speed slows, concentration becomes effortful, and we reach overwhelm far more quickly. The emotional stakes and the uncertainty are also higher. People are worried about their declining function, about losing their independence, or simply by making the wrong choice. At the same time, the system itself is really complex, and the information asymmetry adds to the confusion. After years of dealing with health services, assessments, crises, and paperwork, decision fatigue is almost inevitable. So the opportunity for behavioural economics is when decision environments are harsh, decision quality is compromised, and heuristics dominate, which means people can be nudged. By this point in the story, we've already established that humans, even competent, thoughtful ones, with all the time in the world, are subject to decision biases. So those biases become louder when the environment is harsh, like home care budgets. It's not a calm, reflective Sunday afternoon with a cup of tea and a spreadsheet. It's a bruised hip, a worried GP, a neighbour with opinions, volatile health status, uncertainty, a ticking clock, and a system that expects you to make high-stakes choices with imperfect and confusing information. It is also the kind of environment perfect for nudging. A nudge is simply a small change in how choices are presented that makes one option easier, smoother, more structured, more salient, or more appealing than another. Now, nudging itself is not inherently good or bad. It's like fire. You can use it to cook your dinner, or you can use it to burn down the house, hopefully not one after the other. It is a tool, and tools only become ethical or unethical depending on how we use them. If we know that certain services genuinely help people remain at home longer and others don't, then nudging becomes a way to support autonomy rather than undermine it. But if we nudge in the wrong direction towards services that feel comforting but don't improve outcomes, we can cause harm. Not the dramatic headline-making harm, but a slow, quiet harm. There's earlier functional decline, earlier transition to residential aged care, avoidable hospitalisation, earlier loss of independence. So how do we figure out whether we are moving toward option A or B? Home care has been around for a long time, offering a triple benefit to our aged care system, where people want to stay home, governments want to reduce spending on hospitals and residential aged care, and if we can keep people healthy at home, it reduces avoidable hospital admissions. While all of that is true, the reality is we don't actually know how to move towards this end. In the history of home care in Australia, we've never actually stopped to ask whether home care works in the way that we think it does, why it even works, or how we know that it's working. A recent example is consumer-directed care, a policy rolled out with enormous enthusiasm, representing one of the biggest structural reforms of home care to date, but with zero mechanisms to evaluate whether it delivered what it promised. We didn't measure outcomes, we didn't track service patterns, and we didn't build the data infrastructure to understand what was happening. Now, with support at home, we're repeating the pattern. Another major reform, another redesign, another round of this will fix it, but still without the basic tools to answer the most important questions. Is it working? If it is, why? If it isn't, where is it breaking? And if we're serious about these large-scale evaluations, we actually need data, because without it, we're guessing, confidently, enthusiastically, and often inaccurately. Now, Australia produces enormous volumes of health and aged care data. We just don't use it very well. We generate assessments, service records, hospital episodes, quality indicators, and provider reporting, yet almost nobody has access to this information that can convert the data to information, actually gets to any visibility of it. Publicly available data is at least a year old, and access to person-level data can take 2 or 3 years of approvals. Providers collect rich person-level information, but they cannot, will not, or are legally prevented from sharing it. Privacy protections are essential, but they are also prohibitive. Without person-level linked data, we have no visibility of system function. And if you do happen to get access to this kind of information, you inherit the proverbial Gordian knot. You have multiple systems, incompatible formats, missing fields, and no reliable way to link the data sets together. So the data exists, but it's fragmented, inaccessible, and almost impossible to use for any meaningful evaluation. So when I began this work, I spent an extraordinary amount of time simply trying to find a data source that could answer even the most basic questions. And I faced the very real possibility that my PhD would be finished before I had access to the data I needed. I therefore have a genuine professional curiosity to know, as people working in this system each and every day, where does your data come from? So I invite you again to just share a comment on the QR code. So just share the amazing word cloud that's generating in the background while everyone puts in their responses, and I thank you for that. There's some very common players, the aged care surveys, AIHW, all of the sources that we kind of tried to have a look at. So as a PhD student, I faced the same data barriers as every other Australian health services researcher, although I had an unexpected advantage, and that was my supervisor's connection with NARI. NARI is an international suite of standardized clinical assessments with global distribution, and in Canada, it is implemented at a scale that Australia has never achieved. The Canadian Institute for Health Information collects all NARI assessments, de-identifies and cleans them, and distributes them to approved institutions, including NARI Canada at the University of Waterloo. Waterloo holds one of the world's most comprehensive repositories of linked person-level assessments across multiple care settings. Access is tightly governed, but once admitted, researchers can work with rich longitudinal data that supports advanced modelling and system-level evaluation. The data set that I used for my project started with 3,934,588 assessments. So these assessments belonged to 1,771,929 episodes of care, detailing the experiences of 1,383,771 Ontarians from 2010 to 2018. So very, very big numbers. Canada's data environment allowed me to test my hypotheses about heuristic decision-making in home care with real-world evidence. The holdings were large, detailed, and linked well enough to examine longitudinal patterns and identify associations between service use and length of stay in home care programs. My earlier work had already shown that home care recipients rely on heuristics and generate predictable biases. People can be nudged, and my experimental work demonstrated that nudging can influence choice without limiting a person's autonomy. It also highlighted the ethical imperative to be certain to nudge in positive directions, if only we knew what they were. The Ontario dataset provided a foundation to begin answering that question, moving beyond theory into examination of decisions, services, and outcomes unfolding in the real world. So with a dataset of this magnitude, I could examine functional decline, cognitive decline, service delivery patterns, transitions to residential aged care, hospitalisation, and death. For my analysis, I focused on 3 outcomes that helped describe home care trajectories. So the first was length of stay, simply the number of days in an episode. That seemed a sensible way to think about measuring the program objective of aging in place. The second was discharge destination, which reflected transition points in a person's healthcare journey. Ontario has 13 discharge categories, including extended hospitalisation, long-term care, which we know as residential aged care, assisted living, other community services, and death. The third outcome variable was whether the episode was completed, which was created purely for time to event modelling. So episodes that were still active at the cutoff date were censored, allowing the analysis to accurately reflect real-world patterns even when episodes had not yet concluded. For exploring service use, the dataset contains some very useful information. Canadian home care service offerings are not vastly different from Australia with respect to the type of service, though prescription and policy settings are a little bit different. For my analysis, I focused on 9 services that roughly align with Australian home care package offerings, which are there on the screen. And each of them plays a different role in keeping someone safe, functional, and connected at home. By looking at how often people receive services and how that changed over time, we can start to understand which combinations of services are associated with longer episode durations. So to understand how services relate to length of stay, I needed to look at 2 things: whether a person received the service at all and how often they received it. The 427 item RIHC tells us how many days each service was received in the week before every assessment. That means that we can see not just what people received, but how intensively they were using different types of support. These are related, but they tell us different parts of the story. So for service type, I created a simple dummy variable, 0 for no service and 1 for receiving a service. And then for intensity, I created a categorical measure of frequency. Anyone who didn't receive the service was coded as a 0, 1 to 2 days was low, 3 to 4 days moderate, and more than 4 days was a high intensity. And then to ensure the modelling reflected real differences between people and episodes, I included covariates drawn directly from the NARI home care assessment and administrative data. These captured demographic factors, regional variation, clinical complexity, caregiver support, and episode timing. A few important ones to point out: the NARI client identifier is an anonymised number that follows a person across all NARI assessments, allowing their care journey to be tracked across programs now from cradle to grave in Canada. And a couple that are unfamiliar to Australia are CHESS and MAPLE. So CHESS is the Changes in Health, End-Stage Disease and Signs and Symptoms scale, which measures health instability and is a strong predictor of decline and mortality. MAPLE is the method for assessing priority levels, which summarises clinical complexity and care needs, is widely used across Canada to guide service allocation. All of these covariates combined allowed me to isolate relationships between service use and home care trajectories, reduce bias and confounding in the observations. So in the beginning, my research question seemed really simple, but answering required a substantial amount of analytical work. I began with descriptive statistics to understand service use patterns and the characteristics of long-stay home care recipients. I then wanted to examine interactions between service use and episode duration, so I looked at time to event modelling, beginning with a Cox proportional hazards model. These models are purportedly well suited to health services research because they can handle incomplete episodes and varying lengths of stay while focusing on the timing of real-world events. I also needed to account for time variance and recruited multivariate regression and fixed effects regression that aim to capture within-person changes, account for differences across individuals and episodes. So together, these methods provided a comprehensive way to examine how service choice and outcomes unfold over time in a program where stability, decline, and transition are constant features. So on to the results. I know we're moving very fast. Results for the discharge outcome are shown. So the 13 destinations were grouped into 5 categories that aligned with expectations of home care discharge in Australia, roughly. The largest discharge group is care plan complete. So the goals of the care plan had been met or the episode had reached a natural conclusion. This is not yet a feature of Australian home care, though it will be interesting to see how this evolves as our policy shifts towards reablement and maintaining independence over the longer term. Hospitalisation and long-term care transitions make up the next largest groups and account for nearly 40% of discharge outcomes combined. These are the discharge options perceived more negatively or as a program failure, so we would like these to be associated with longer lengths of stay. In Australia, people aren't formally discharged from home care when they go to hospital, but extended hospital stays are becoming more common as people wait for appropriate home care arrangements or transition to residential aged care. And a not insignificant portion also died while in the program. So it's worth mentioning that death as a static data point in this kind of research is not especially meaningful because it is an anticipated outcome. What matters is not the count, but the quality and timing of the death and whether some deaths occur earlier than expected in particular cohorts. So additional meaning can be gained by shifting from counts to associations with length of stay. In the box plot here, you can see that death appears to have a longer than average length of stay, which is actually a positive sign. So it suggests that people who die in the program often remain at home for extended periods, supported by services that allow them to stay in the community rather than experiencing premature transitions. Death is unavoidable, but the trajectory leading to it can give us important details about the quality of care. We can also see here the impact of service plan complete. This is the little one on the, just in here, the first one. It can represent successful episodes where the goals have been met and independence has been maintained. So in this respect, we actually want the episodes to be shorter. The combination of positive and negative associations with either long or short episode duration muddies the interpretation somewhat. So hospitalisation and long-term care transitions also show different patterns of length of stay, reflecting complexity of health instability, caregiver capacity, and the limits of what home care can sustain. There is a subgroup analysis of discharge categories that explores features of each cohort, but there were only so many slides that I could fit into today's presentation. As you may have observed on the box plot, with the heavy concentration of outliers, length of stay in home care is highly skewed. Most people remain in the program for less than a year, while a smaller group stay for several years and a smaller group again remain for over a decade. This long tail pattern reflects the heterogeneity in home care that exposes how difficult case mix calculations are. Understanding this distribution is essential because it shapes how we interpret service patterns, how we model time to event, and how we think about nudging within a system where most episodes are short, but a meaningful minority are very long. The regression models also help clarify which factors were most strongly associated with length of stay and how different types and intensities of service use related to stability in the home care program. There were a lot of tables, so I've cherry-picked a few high-level results just to discuss today. So due to the size of the sample, most statistical tests were highly statistically significant. Clinical instability and care complexity were consistently linked with shorter episodes, reflecting the reality that people with higher CHESS and MAPLE scores transition sooner simply because their needs escalate more quickly. Service effects were present but variable. Some services were associated with longer stays, others showed smaller or more complex relationships, and the direction and strength of these effects shifted depending on whether we looked at service type or service intensity, or even the univariate to multivariate analysis. The fixed effects regression added another layer, showing how changes in service use for the same individual related to changes in their assessed needs, independent of stable personal characteristics, and to directly observe the impact of different service types and intensities on length of stay, particularly the regional variations. So, looking across these results, we see a system where people's trajectories through long stay home care are shaped by clinical need, regional practice patterns, and the mix and intensity of services they receive. So even at this high level sprint through a limited number of variables, you can see a mix of positive and negative discharge outcomes, a desire to sometimes want short episode lengths and other times longer, and highly skewed data distributions. And I'd like to invite some reflection here because I'm only one researcher and I'm looking at this very large and complex system. The patterns raise questions that deserve more than one perspective. And so rather than walking through every single question, I simply request that you click through and share any reflections that resonate with you. I have learned that home care is dynamic, needs change, risks change, and the role of services change with them. Understanding that complexity requires collective interpretation, not just my own. So I am genuinely interested in how these findings connect with your knowledge, your practice, and your expectations of the system.
I'm thinking, Danelle, while people are answering that, might be good just to flick back to that previous slide, the one that had oh, maybe it's two before. Yeah, no, that one, because I don't think that you sort of went through and explained the PT, OT.
All of them, yes. So
yeah.
They are the service types. So again, just really cherry picking some of the results. So people who received services very intensely had a longer length of stay. So we have the personal support worker, so what we know as domestic support, nursing services, physiotherapy. So if you had very intense personal support work, then you could expect to get a half a day. Nursing a little bit, physiotherapy an extra 4 days, and occupational therapy an extra 11 days. Then when we look, so the Y is the binary variable, the yes, no. So if you did receive physiotherapy, then you had an average length of stay 214 days longer. If you had OTs, 107, personal support workers, 219, and nursing 88. So these are all just indicators and associations. We can't really say. There's a lot of confounding, which I will talk about in a little bit, but we can kind of start to see directions between how often somebody receives a service, how much of a service that they're receiving, and the impact that that has on their stay in long-term home care. And so the therapy services particularly, we see there the speech and language pathology. These are very complex people. And so the speech and language was a service that was associated with a shorter length of stay for people receiving very intense speech and language pathology. Clinical complexity as well. There's huge variation between the days. So across the different chest scores, you had 17,000 days as a variance, and for MAPLE 615. And then again, the regional variation. So there was an average a variance across the regions just simply by being in that space of 2,596 days. So even when we remove clinical and service factors, those patterns persist. So there were a lot of tables and a lot of findings, and just trying to distill them down into a 30-second slide.
Yeah, I'm looking at that chest variance. That's a lot of years difference, actually, isn't it?
It is. It's massive. Yeah.
Yeah. And the PSW, are they more like, you were saying cleaners, but I don't, is that right? Yeah. Or is it more like the personal support, as in showering and assistance with personal cares?
They combine them.
Yeah, okay.
They have a home health aide.
Okay.
Yeah. So the personal support work is more like the domestic assistance in Canada.
Okay.
Okay, so I haven't got many results there. May have clicked back too fast for people to get the QR code.
I think it's tough questions you're asking.
Yeah, so they're just about patterns, and we keep going and come back to that if you like. And I believe the slides will be available, so I'm more than happy. I will be using this for my own reflection and research, so I will come back to the responses over the next couple of days. And so, as we just demonstrated with that quick run through over the results, my research isn't perfect. Survival analysis was a useful early step for examining time to discharge, but every model that I tested violated the proportional hazards assumption, especially for service-related variables and measures of clinical instability. So what this meant is that the effect of covariates on discharge risk wasn't constant over time, limiting the interpretability of a hazard ratio, introducing bias if I continue to assume time invariance. In hindsight, this is exactly what we'd expect in long-stay home care because needs evolve, services fluctuate, and the relationship between support and risk changes as episodes progress. I did explore some time-varying covariate stratified Cox models, Schoenfeld-based adjustments, which did help, but they didn't fully resolve the underlying issue. So when service effects shift across an episode, the literature points us towards methods that capture within-person change rather than relying on the proportional hazards, which is why the fixed effects regression became central to my analysis and why future work should consider things like service trajectories, sequence analysis, or transition-focused approaches, which may better reflect the dynamic nature of home care episodes. So another aspect that complicates translating these findings into home care practice is confounding. Long-stay home care involves overlapping needs, bundled services, and complex interactions between supports, which means many variables move together or are derived from one another. This creates multicollinearity and makes it difficult to isolate the independent effect of any single factor. So when we compare simple univariate patterns with multivariate models, we see the results can conflict even when they're statistically significant, which inflates uncertainty and obscures true relationships. So despite the NARI assessment containing 427 items, still can't rule out latent variables that influence both service allocation and discharge outcomes. Things like organizational culture, unmet needs, policy positions, workforce biases, and clinical judgment aren't directly measured, yet they shape the services people receive and the transitions they experience. And the absence here introduces a bias that can't be fully resolved with simply observational data. This is particularly relevant when we're trying to move beyond association and establish causality. So without randomization, we can't disentangle whether service influences outcomes or whether underlying need drives both service use and discharge. Even with careful model specification and fixed effects regression, the direction of causality can't be definitively established. Essentially, these results can only be interpreted as associations shaped by a complex system where need, support, and services interact in ways that are only partially observable. And there's some implications as well. Although this analysis uses Canadian long-stay home care data, the patterns do have meaningful implications for us here. The results highlight how strongly clinical complexity, support capacity, and service mix shape people's trajectories through home care. All of these are central issues to our current home care reforms, and they show that needs evolve quickly. Service allocation isn't linear, and stability often depends on the right mix of support. A major difference is that Ontarians don't actually choose their services. Care coordinators allocate them. So we can't assume that Australian patterns will look the same, and we won't know how choices interact with needs and outcomes until comparable Australian data sets exist. Ontario also differs in governance, assessment tools, funding mechanisms, and long-term care availability. So the results here are interpreted as signals rather than predictions. The value of this work lies in what it reveals about how people move through care systems and how similar analyses could help evaluate Australian programs against the outcomes we actually want to achieve. The length of stay patterns in this analysis show that people move through long-stay home care in highly variable ways. So in principle, length of stay should be a straightforward measure of success and an indicator of how long people can remain safely at home. But as we saw, this only holds when episodes are continuous and all discharge outcomes are likewise undesirable. In practice, long-stay home care is fragmented. People move in and out of services, experience gaps, return after hospital stays, or shift between programs. These interruptions make it difficult to interpret episode length as a clean outcome. When episodes are broken, a long stay may reflect stability, unmet need, or delayed transition, and a short stay may reflect either rapid decline or improvements, such as meeting all of your care goals. Without continuity, the meaning of length of stay becomes ambiguous. If we want to use length of stay as a measure, then we need to distinguish between uninterrupted care trajectories or disruptions from system-driven or person-driven transitions. Only then can the length of stay function as a reliable measure of success and help identify where the system is under strain or where our interventions might matter. So one of the strongest implications is that decision-making in home care is complex, multifaceted, and iterative. Older people are expected to make choices in environments of uncertainty where needs shift, services are inconsistently applied, and information is incomplete. In principle, good decisions should be a straightforward lever for improving outcomes and system efficiency, but only when the environment supports them. The patterns that we've seen today show how easily decisions can be distorted by noise, changing needs, organizational practice, and the pressures people face when they're navigating their care. Decision hygiene isn't about making perfect choices. It's about reducing avoidable errors. Structured assessments help, but don't eliminate cognitive shortcuts that occur when people are under pressure or when service availability shapes choices more than service need. A key point here is that environments are easier to change than people. We can't redesign cognition, but we can redesign the conditions in which decisions are made. Older people shouldn't have to be making these complex choices alone. They should be supported in ways that improve their well-being and autonomy, not simply what is easiest for our system. We can introduce scaffolding that simplifies choices without limiting their options and create an environment where good decisions are more likely, where the system can nudge in ways that genuinely support people with increasing care and support needs. And whilst I don't anticipate any objection to that sentiment, now is likely a good time to point out that even the choices we make over which scaffolding to incorporate is complicated and fraught with danger. After completing my PhD, I have some ideas, but these ideas aren't necessarily viable. I can and did hide behind the more research is needed catchphrase, but it still remains true. Case mix in controlled environments remains a poor predictor of costs and outcomes, and so we assume it can only be worse in the uncontrolled and largely invisible home environment. So once again, I invite your thoughts and feedback on where this should go next. What are the objectives of home care as you see them? How can we measure them? What services deliver the desired outcomes in the most cost-effective way? And once we know that, how do we convince policymakers that these are considerations to accommodate before we launch new programs and policies? So these are all very tough questions that take many years and not a few seconds to answer, but I do appreciate the input. So my research was never really about finding a perfect model. It was about understanding which way the system needs to be nudged to support better outcomes. A key insight that I took away is that nudging isn't limited to older people. Every system player is influenced by their own heuristics and the environment in which decisions are made. The most effective nudges may target providers, assessors, or policymakers because changes at these touch points ripple through the entire system. The patterns in length of stay show where complex, the regression results show where support structures hold or falter, and the confounding reminds us that services operate inside a web of need, capacity, and organizational practice. These signals point to the places where the system bends, where it risks breaking, and where nudges might have the greatest effect. Future work needs to identify these leverage points in Australian data and policy settings and take ethical tension seriously as reforms evolve. And so that brings me close to the end. But before I divulge my final takeaways, I'd like your reactions and reflections one final time. Was there anything new and surprising for you from this presentation, or did it make absolutely perfect sense? Was the conclusion obvious, but coming from a perspective you may not have considered before? And who else needs to see this information in order to promote positive change?
Is that the final slide?
I've got two more, I think. Those are my key takeaways. Because I am a behavioralist at heart, we know all about heuristics and biases now. I know that the last thing you hear will be the first thing you remember. So the principal thoughts that I'd like to leave you with today are these. Aging and people are complicated. Home care is a dynamic system, not an individual service or program or provider. Services do matter, but not in isolation and only when they're combined with the right mix of support and context. Decision hygiene is the primary ingredient in effective decision making because systems are noisy and small errors now can shape major outcomes later. And finally, we owe it to our oldest and most vulnerable people to know which way to nudge. I do thank you sincerely for speedboating through home care trajectories and decision making with me today. I appreciate your interest and would love to hear any ideas, disagreements, or curiosity that this knowledge sharing might have sparked. If we're not already connected, then we absolutely should be, because I believe strongly it's the easiest way to keep the conversation going and the research flowing to navigate through the next uncharted territory for home and aged care services. I'm happy to take questions if there's time, or you can send me a message. Thank you.
Thank you very much, Danelle. That was great. And I've got about 10 minutes, I guess, for questions, but I just wanted to start, I guess, and I think some really strong evidence for allied health, which is nice to see, that came out of your research, but also, I guess, those home care workers. And I wanted you to comment on, I guess we've had a major nudge reform in the previous, in the new Aged Care Act and the new Support at Home program in the co-payments. That's a big nudge. Yes. And one of those nudges, which has been pretty contentious, I guess, is around that co-payment for home care and personal care workers, although some of that's been rolled back already. I just wanted to get your comments on that, in the context of your research.
So I will straight up say I am a little bit biased and am against the co-payment idea. I do acknowledge that there should be some mechanism where if you can afford to make some contributions towards your care, then you should. And I do feel, particularly at the start of this research and being an allied health clinician myself, I would like to see more of that healthcare base. But after spending some time looking at home care and people making the decisions and what they need to stay happy and healthy at home, I think that they need to be focusing on the outcomes and the services rather than what people should and shouldn't pay for. So the research over my my PhD indicated that people would choose home care services because they were cheaper and they often couldn't afford to include the allied health interventions that they needed. And so allied health, while it was recommended a lot, was very rarely selected. So it is positive to see that there are systems that support that, but overall, how the funding model is shifting the buying power is more of an issue. So the co-payments should be equally applied across the service range and should be similar to what the income assisted fee was, rather than skewing any one way in particular. And we should be focusing on the outcomes of the care. So does getting somebody to clean your house, and as we saw in Four Corners last night, the often they're not even able to provide the cleaning, so they're receiving payment for a service that's being done by somebody's children. That's not acceptable, not appropriate. It should be, how do we support people? How do we keep the environment hygienic? And how do we encourage the services that we fund to actually focus on, is this keeping the person at home independently? So that's what we should keep coming back to. And that we don't have any visibility really at the moment on what services people receive that help them stay at home independently. So, you know, is it something that they can engage in re-ablement to be able to do themselves, similar to what we saw in the opening question? Or is it something that we need to think it's not actually worth us funding that particular aspect of it? As most people would be well aware, there's never enough money to pay for everything. So what should the government kind of prioritise? And the questions that they have are, do we do, you know, a little bit across all of it, or do we focus all of the resources on one particular thing? And that all needs more research and analysis. Oh, you're mute.
Mute, sorry. There's a question on our Q&A from Susie Byers, just talking about the Four Corners report last night. That really highlighted the prioritisation of need calculations don't appear to be working well and are creating a lot of stress. Any thoughts on how your data could assist in providing what might be a solution or a good way forward?
Now, again, my biases will be showing here. From working with systems, the department have a very good point in that an algorithm will be a lot more consistent in the way that it reaches a decision. It isn't swayed by affect, in any sense of the word. However, the tool is only as good as its design. And I feel that the government have tried to reinvent the wheel in-house themselves, and it has fallen short. So the removal of clinician override and human oversight has been problematic, and their reluctance to discuss how the algorithm arrives at its decision, and the fact that it excludes all of the qualitative information that the tool provides, raises a lot of eyebrows. And so the Senate and the wider population, the Association of Gerontologists, have very valid concerns and complaints about the instrument. I feel that there is enough evidence internationally that we can develop an algorithm that is fairer and considers the entire gambit without having to invest many millions, even billions of dollars in reinventing a wheel that already exists. So we should be learning from already available resources rather than going back to the drawing board.
Great. Thanks, Danelle. Does anyone want to raise their hand or unmute and ask a question? We have a lot of people online, and nobody willing to. Susie, do you want to just talk to that point?
Yes. Am I unmuted?
Yes, I can hear you.
Thank you.
Yep.
Thanks, Danelle. I think the complexity for what I saw and the heartache of what we saw in the report last night related to the stress that pushes back down the line onto informal carers. And, you know, it's great if you've got a very supportive family, someone who can come and provide that level of comfort as well as help you navigate the system. But, you know, the reality is we know there's a lot of people who don't have that level of support. So, you know, I think that was the challenge last night of, if someone's, you know, allocated as needing something, but their prioritisation is pushed way down, you know, how are we even measuring the impact, and what can we encourage policymakers to think about in terms of the complexities of the measurement? And so, you know, their evaluation and the way they're measuring outcomes is super important, and they need to, you know, think about how they do that better.
I completely agree. And I think the other point to take away from that is these issues that people are experiencing in home care support at home at the moment are before they've even got to the service provider. So the work that I've presented today is talking about what happens after that decision. So you've chosen your services and you're already receiving them. That a lot of the issues are being driven at the moment by these excessive wait times and having to wait for the assessment or being continuously told. So the no worse off is not tight. It's only the monetary figure. It doesn't take into account the 38% inflation that we've had on prices since transitioning to a unit price model. So all of those things are policy questions that we can't really do much about once you're at that provider level. And so I think that's an added layer of complexity that's been introduced since my PhD finished. It is really grappling with the impacts of the policy and a sector that's madly scrambling to try and make sense and provide a cost-effective service. We're seeing a lot of providers kind of collapse under the weight of the new framework.
And lastly, Tracy, that's my last question, is, years ago we used to have a person, like a coordinating person allocated to people to help coordinate the system. We seem to, again, be pushing all that back down to informal carers, whether that's a good friend or a family member or maybe even a very helpful neighbour who can see the distress. Is there an opportunity here to encourage policymakers to change the environment and put in more help rather than try to fix the system at the moment, at least put in an intermediary step to help people navigate, the system as it is? Do you think that's helpful?
Yes, I do. And I think the sentiment is there with the care management. I don't know that it's been executed particularly successfully, but the idea is that the providers almost function as that navigation service and that coordination service to support the older person, even in cases where the older person is self-managing. So I don't think we've got it all figured out yet. As was highlighted in that report last night, there's a lot of challenges and questions for the department to think about in terms of their policy. But I agree that it's made a system that was already complicated and difficult to navigate and understand even more so. And so we need to go about unpacking that. And that's not necessarily a provider question. I think it's a question for the department.
We've got time for one last question. Please, so Alina, would you please come off mute and you can ask your question.
Oh, yes. Hello. So I'm a mental health clinician working in Victoria, specifically with older adults. And so I'm just going to sort of ask a question. Don't necessarily expect you to be able to answer it because our mental health system is quite fragmented and this is adding extra complexity onto this already complex issue. But in terms of older adult mental health feeding into this provision of care, because we rely heavily on NDIS and we actually recommend people stay on the NDIS than go on to aged care, even though they need aged care. So I guess more so what I'm wanting to sort of ask you is, where do you sort of factor in mental health as this sort of variable in all of this research, because it is a growing and very underfunded area of aged care?
Absolutely, and this comes back to a more holistic approach, or even we've now graduated to like an ecosystem approach to aged care. So in the Canadian data set, the mental health is represented there, and it didn't it wasn't taken up or prescribed or recommended extensively from that 2010 to 2018 period. It's definitely improving and increasing in visibility and significance. But what we know, as similar to the allied health versus personal support question, people have different needs and they are across different aspects and different spectrums. And so mental health, especially the loneliness and of course, dementia. Like dementia is a significant driver of early entry, early transfer to residential aged care, and for extended hospitalizations. And we definitely need better ways of working with those people to support their health needs as they age. And so the support at home, the home care environment is a very complex, different environment to any healthcare environment, because it's not exclusively what we consider traditional healthcare to be, that physical kind of, going to the GP, getting your medications and things like that. It is a whole system, a whole person, the environment that they live in, that they control. It's not within the control of the provider, what happens in there. And so we don't actually get to see what goes on in there a lot. But as I say, loneliness, connectedness to community, that's another big feature, I guess, of home care that's becoming more prominent, and the support workers, so the people that companion work, like the cup of tea actually kind of might be more important than we tongue-in-cheek give it credit for. And so I think that the visibility is increasing, and I think it's an important consideration as part of the entire care ecosystem. So it should be in the assessment forms, and it should be one of those health needs that is assessed. The fragmentation.
Danelle, I'm gonna stop you now because we're over time. And
yay!
People are going on, but that's great. So can everyone, put a thumbs up or clap? Join me in thanking Danelle. I think that was a great talk, great discussion at the end.
Thank you.
And obviously we'll have that up on our website in a few weeks. So I'd like to invite you to join us for the next Seminars in Ageing webinar, which will be the 8th of September, and that's featuring Associate Professor Lillian Hung and Dr. Jim Mann presenting from Lived Experience to Innovation, How Intergenerational Patient-Orientated Research Shapes Technology for Ageing. And thank you all for your ongoing support of Seminars in Ageing series, and look forward to welcoming you again in the future.
Thanks,
everyone.